Just gonna give it a minute. Wow, everybody got real quiet. It's the fresh air on the walk. Thank you, Amanda. That was awesome. Yeah, for those that weren't on the walk, Amanda guided us, and like I learned all sorts of new facts as well. So that was great. A little guided walk and some learnings too. So I think there's a few people that are just walking in. Yeah, feel free to join us. So I know some people had to leave, and so there's some comings and goings, and grateful that everyone that was be able to be here could spend as much time as they were. We do have some people online as well, and just a reminder that everything is recorded as well, so the sessions will be put up, including Kim. So, as one of the co-hosts, I took the liberty of getting to introduce Kim, and I no, don't be afraid. I actually spent a lot of time thinking and sitting with how I was going to introduce you, because I think that, and I know Bahar's here and Kate had to leave, but I do feel like this feels like kind of a circle. Not my research lab, but like a true circle of, we're on a run this morning. I looked at Kim. So I did my postdoc with Kim, and Kim was, I think, what we talked about a lot today, and that was why it was so important for me and Kelly to have so many trainees in the room, because I think that that is what the Applied Public Health Chairs program is really meant to do, is to foster and nurture the next generation of scientists. And so Kim was all of the things in the room that we talked about, of all the things that I want and I need, and I hope I don't cry. Like, I would be standing up here today if it weren't for Kim, but I wouldn't be standing up here in this role 100%. So I always say I learned everything from Kim, and she is my hashtag life goals, from not just from a science perspective and a research perspective. And I'm so excited that my trainees got to spend time with Kim, even though she was in the School of Public Health. She retired before many of my new trainees are here. But not just science, but life, running. We have a shared love of running, which is how I'm going to introduce Kim a little bit today. And Kim's bio is in the program, but there's so much more to Kim. So I always say life goals, and we've star jumped together, and I have pictures of Kim blending in with the wall, but she doesn't blend in anywhere because she's a personality extraordinaire, and brings a passion for science and for life, truly. And when Kim retired, we were asked, one of her former trainees as well, Alexa, and I should say Jenny also. I got to know Jenny, who's worked for me for 12 years. You were a graduate research assistant who I supervised as a postdoc when I was working with Kim. And so Jenny did her master's with Kim. So there's a lot of generations of Kim in here. So we were asked to submit an abstract. And I know I'm taking a little bit of time, but I think it's important, because I think that this is what this chairs program is. And this is why I was so excited to have Kim kind of sum up everything that we've learned about community engaged research, because this is where I learned everything. And the abstract, we submitted abstracts about Kim. And so I'm going to share a little bit from mine. So Kim's read this and seen this, so this is nothing she doesn't need. So I called the objective that we wanted to aim to understand the lived experience of becoming distinguished, because Kim is a distinguished professor. And I will say that this case study research occurred over a 20-some year period. So Kim was also on my PhD committee. And we were gathering the decades that was there. And there was multiple methods. I would say that the data generating strategies include direct observation. There were gatherings near and far, from College Plaza to Hong Kong. Document analysis. There was thousands of emails and texts, photography, and many running meetings. And trying to understand what it takes to be distinguished like Kim is a marathon and not a sprint. And so for those of you that aren't runners, I ask you to bear with me, but for those of you that are, you will understand much of this. So for Kim, crossing the finish line is just as much of an achievement, but the journey is just as important as the destination. The journey requires time, patience, hard work, dedication, and passion. And I would say that those are themes that we've heard about all throughout these last 2 days. I have a few other themes, though, that I've learned from Kim. So one is volume. So to get to the finish line, you have to put in the miles. Some miles are fast, some miles are slow, some miles are hard, but they're always made easier when you do them together. And I feel like that's what we are here as a team. Kim is a natural and dedicated leader and team builder. She knows the miles are important and will be right there with you getting them done, as she was this morning. So recovery. Recovery is also key to success. So recovery can take the form of sleep. In meetings, if necessary, she once fell asleep during a one-on-one meeting with me. She was in the middle of a massive, so I should say Kim has done, I don't know how many Ironmans, how many marathons. She was in the middle of like a massive training block, and she's like, I think I was a little bit out of it during that meeting. I'm like, yeah, you fell asleep. It was just the two of us. Travel, preferably by bike, or hydration. There are many forms of hydration that we've celebrated together with. And Kim, you live life to the fullest, and your warmth and how you live life is contagious. And so keep the easy days easy. Embrace the hard. So Kim really taught me to embrace the hard. Like, some of this stuff is hard, from not just time and energy, but the work. The climbs can be a challenge. Their transitions can be slow, but ultimately the hard is what makes it great. And so Kim was never afraid of the hard, and was a sounding board for others navigating their own growth and their own path. So make the hard days hard. And then sidelines. So I've also learned this from Kim too. You don't always have to participate in the race. So being a cheerleader on the sidelines is often the most important role. Kim is everyone's biggest cheerleader and isn't afraid to step into the background and literally blend in by matching the decor. So I have many pictures of Kim matching the decor on accident, but she never blends in. And lastly, I will say fun, and this is in Kim's bio. It always has to be fun. So with that, I will always be your biggest fan, Kim, following in your very fast tracks, and we'll never stop celebrating with a star jump. So come on up and share your wisdom.
I've been retired for 2.5 years. I haven't done a single academic thing, but when Kate called me to ask me to do this, you can't say no to Kate's story, especially with our. So yeah, okay. You cannot say no to Kate's story. So that's why I'm here. So yeah, I pulled out the shoes that I haven't worn in 2 years, but I couldn't go for the long lunch walk because they're not as comfy as my running shoes, which are packed back at the hotel. So yeah, so I'm so privileged to be here. Thanks so much for inviting me, and I have learned so much over the last 2.5 days, and I've tried to incorporate some of that learning into my talk, because the talk is called Community Engaged Research Looking Back and Moving Forward. And I'm going to tell a story looking back, really my story and the people that I've worked with stories about how we learned what we learned and how we got where we are. But the moving forward, that's all you. I'm retired. Like, that's all you. So this is stuff that, I'll put a few ideas out there, but a lot of those ideas came from you. So that's where we're going in the next 40 minutes. Okay. And I have 40 slides, 1 slide per minute. But sometimes I tell stories and they take a little longer. So it just sort of depends on how it goes. So we'll see. Okay. So the key messages. Looking back, I'm going to tell you a story about how I found and have used community engaged scholarship as a foundation for guiding my work in promoting health. I'm also going to share some case studies, so some historical context in addressing public health challenges that some of you have shared with me, and use that as a way for us to collectively ponder how far have we come. And then I want us to think collectively about moving forward. And I know that's the last section of the day anyway, and that will be wonderfully facilitated by Kari. But one of the questions we might want to consider is, what can applied public health chairs do individually or collectively to advance community engaged research to improve public health? Okay, so that's kind of where we're going. Oop. Looking back, a relatively recent history. So all of this stuff that I'm going to talk about happened in my lifetime. Many of you, especially the trainees, this happened before you were even born. I'm old, but it's a relatively recent history. So I started out, my story is, I started out as a dietitian. So it's a health practitioner in the early to mid 1980s, and I had questions. I had questions about the way we did things. I had questions about why things were the way they were. And so, I was a dietitian. I was trained in the late 70s, early 80s. The sort of guiding way we thought about health back then was guided by the Lalonde Report, a new perspective on the health of Canadians that came out in 1974. And even though the Lalonde Report talked about the health field concept and the environment influencing health, what really was the focus in those early days was a behavioral approach, a lifestyle approach. It was all about, we're going to save the health system money by getting everybody to have healthy lifestyles. Okay. And my career as a dietitian fit right into that. I just have to teach people how to be healthy. And I just have to teach them how to eat healthy. So, but you know what? I was counseling people, and a lot of times things didn't change. And so I thought, was it knowledge? Can't be. I dumped everything I know during that counseling session on that person. They know what they need to do. Can't be knowledge. Is it resources? And at the time, I had done some volunteer work in 1988 with the Nova Scotia Nutrition Council, who wrote a report called How Do the Poor Afford to Eat, which basically compared the food allowances on what was then called welfare to the actual cost of healthy eating. There's no way, absolutely no way. This is before we used the term food insecurity. But that really got me thinking, if you can't eat healthy because you can't afford to eat healthy, is my role to teach you how to budget? No. My role is to help change the system so that you can afford to eat healthy. Okay, 40 years later, it still hasn't happened. So, how far have we come? In some cases, not very far. But I also started thinking about the social environment and how we're influenced by things like advertising and just social events. So the ideas, this is all stuff that is so natural to us now. The idea of the social determinants of health, that term did not come into common use until the late 80s, early 90s. So this was kind of a new way of thinking about things. And I didn't know what to do. So I thought, well, what can I do to make this easier? So I started looking, how can we sort of intervene? How can we do intervention research to make this easier? And so I did both an MA and PhD in the social sciences, partially because I knew that I didn't have any knowledge there. That wasn't in my undergraduate curriculum. But also because the reality was, I was not mobile. I was living in Halifax. I was married. My husband had a job, and we weren't going anywhere. So I ended up finding a place at Dalhousie University School of Education where a lot of health professionals, a lot of nurses went to find ways that they could advance their education and advance thinking in this way. There were no schools of public health in Canada. Schools of public health came in the mid 2000s. There were medical schools that had population health, public health departments, but very few of them had social and behavioral sciences. So, basically looking for borrowing these interdisciplinary concepts from a different field was the only way. And I think for me, it was the best way of moving forward and thinking about reducing inequities. The Ottawa Charter for Health Promotion. You've all seen this, I hope. 1986, right? So there were obviously people who were working in the health field who were thinking about this. We were thinking about, as a professional, and I don't think the pointer works. As a professional, I was thinking about developing personal skills, but strengthening community action, creating supportive environments, building healthy public policy. Those are Ottawa Charter action strategies that all of you are working on right now. But at the time, this was totally novel, totally novel. So my philosophy of research and practice as I was working my way through my PhD was informed by these social science concepts, including this critique of oppressive social forces, social structures, empowerment education with historically marginalized populations. And Kate talked this morning about the Global South. I did a whole course on Paulo Freire, who was a Brazilian adult educator who was working to do literacy education. And he did this by critiquing the environments and getting people on board. And it was just, this was kind of cool. I'd never thought about these things before. A lot of the stuff I was reading was written in the 60s around the women's movement. And, so there was all of these new ideas that I hadn't been exposed to before. Participatory research principles. There were a couple of different terms being used: participatory action research, community-based participatory research. And as Kate again reminded us this morning, Nina Wallerstein, who was a health promoter at University of New Mexico, she talked about using community-based participatory research and having to unpack the backpack of privilege in order to do this. So it was only after being exposed to these social science concepts that I started to see that there were other people in health, like the Nina Wallersteins and such, who were actually applying this. And so I started reading in that area. So I really came to this, my research and practice, my PhD and my early research was built around seeking evidence to question what is now termed the determinants of health. And so I had a paper on the social organization of nutritional inequities, still didn't use the term determinants of health. Explore potential avenues for addressing those determinants, so using participatory research, community organization to address those inequities, and working in partnership with our multidisciplinary colleagues for social change to improve the health of populations. I still think of myself in terms of where my passion is. It's for changing. It's for social change, changing the social environment to promote a more health promoting environment. So this is where I start to tell you about mistakes that I made. So building a research program in the 1990s, I finished my PhD in 1993. I didn't do a postdoc. I got a faculty position at Mount St. Vincent University in Halifax, so predominantly undergraduate university, teaching in the dietetics program. And there was no CIHR back then. CIHR didn't come on board till 2000. So there was the Medical Research Council, which was predominantly for basic and clinical research. But when it came to public health issues, it was underneath the umbrella of Health Canada. There was the National Health Research and Development Program. And they worked on strategic health initiatives, research initiatives. With my first grant as a PI was very opportunistic. And it was based on a request from the nutritionist from Medical Services Branch, which is the precursor to First Nations and Inuit Health. And it aligned with an NHRDP strategic call for research on diabetes in Indigenous populations back in 1994. So I was listening to the talks yesterday, especially listening to Jolie and Tina talking about what you should do and you shouldn't do when you're doing research, participatory research with Indigenous communities. Yeah, I made a lot of mistakes, okay? So I'm just putting it out there. And I started thinking, was this a community-driven project? And I actually don't know, because I was asked to, I was a new faculty member. I didn't have tons of things on my plate. I had the opportunity to develop a research program. I was asked by someone who worked for the government, but worked with the community, with the Mi'kmaq communities, if I could be the academic on a project. I was asked to develop the proposal. Did I develop the proposal in collaboration with the community? No. I was introduced to these communities by this nutritionist, and I didn't do any research until I met with Chief and Council and went through the whole process. But I actually don't know if those communities asked her to find them someone to help them through this, or whether she was the one who was initiating this. I actually don't know. So, in terms of the do's and don'ts that Tina was saying yesterday, I'm thinking, oh, did that. Yeah. So, but again, think brand new academic, no postdoc. Yeah, I just did what I needed to do to get my first grant. So Cape Breton Mi'kmaq Communities in Diabetes was the name of the project that we worked with. And really, I was looking at exploring the social determinants, and I did use that term in this grant, the social determinants of diabetes through community based participatory research. So, like I say, made some mistakes, but did end up having a wonderful relationship with the communities, hired local community people to work on the project. And basically, community members were telling me their experiences, their lived experiences of healthy eating, physical activity, and things like, this is a sign that says Sydney Tar Ponds Cleanup. This was at the time Canada's worst environmental disaster. It was basically a lake where the elders used to fish, but it was where all of the waste from Sydney Steel Corporation was deposited. They could no longer access that water. I worked in one community called Membertou, which was actually an urban Indigenous community. No access to land for hunting. They were in a city, the city of Sydney. So, these were things that I started to talk about, and we started, and in the type of research methodology that I was using called institutional ethnography, we talked about using people's experiences as point of access to broader social structures. So the whole colonialism, the movement away, the lack of access to land and water and traditional ways of gathering food, those were things that came through and that ended up being part of this project. There were about 7 projects, I think, that were funded through this. And one of them, which I'm going to talk about a little bit more later as a case study, but one of them was the Kahnawake Schools Diabetes Prevention Program. And KSDPP started with this same funding back in 1994. And what I was reflecting on for the past few days is that I still keep in contact with a couple of people in this picture, Dr. Anne Macaulay, who again, a white settler, but worked as a family physician in the local hospital, who was a resource to the community. Dr. Alex McComber, who was the first research coordinator for KSDPP, but he was the principal of the Kahnawake Survival School. So he had access to the schools. And then the other person in there is Trina Delormier, who was Kate's first PhD student, who is a community member and lives in Kahnawake. So this project started, and what was interesting, let me see, what's my next slide? Yeah, so the origins of the KSDPP began in 1994, community-driven. It was the request of community elders after baseline research by people like Anne Macaulay, who showed the high prevalence of type 2 diabetes and complications, which was considered a death sentence for many of the community members back then. It was designed as a community-based participatory research program with the community, and they had a KSDPP Community Advisory Board, very similar to the ARC that we heard about yesterday in Alexander. And they had community researchers and academic research. So one of Kate's colleagues, Louise Pavin, was on in the early stages, but as capacity started to be built, stepped away, and the project was taken over. They developed a KSDPP Code of Research Ethics, which may very well be a model for what was developed in Alexander. And they developed interventions that were, informed by Indigenous perspectives, but also by a lot of sort of traditional Eurocentric theories, like the pre-seed-proceed model and the Ottawa Charter for Health Promotion and social learning theory. So that's where they started. And they evaluated changes in sort of traditional health outcomes, knowledge, behavior. They were working with children, so they weren't looking at diabetes prevalence back then. But things like knowledge and behavior were what their outcomes were. So I just want to add one thing to this story is that, and this just popped into my head this morning as I was having a shower. The 7 groups that were funded under this were brought together. And the person who brought us together, and I don't know why, I don't know what his role was at the time, was Dr. Jeff Redding. And Jeff became Jeff became the first scientific director of the CIHR Institute of Aboriginal People's Health. But he brought these groups together so that we could share, so that we could learn from each other, so that we could move forward together, so that we had common common knowledge and common advances. And he was the one who said to me, this social determinants of health thing is really interesting. Can you write something up on this? And I'm like, okay. But, people just weren't doing things this way back then. Okay, so in the mid-1990s and the 2000s, there started to become an evolution in population and public health intervention research infrastructure. So academic health promotion centers started in the mid to late 1990s. I actually joined one of those health promotion studies centers in 1997, the University of Alberta Center for Health Promotion Studies. And these academic health promotion centers, one of the first ones was University of Toronto, led by Irv Rootman, who worked at Health Canada prior to going into academic health promotion. And so all of these health promotion centers were structured around the idea of community partnership. So it was a really great opportunity for academics to connect with community, to do the research that the community needed. There were also lots of things. I did a lot of work in chronic disease prevention because of my nutrition background. And so, so the Canadian Heart Health Strategy and Action Plan, I worked with the Alberta Heart Health Project, the Nova Scotia Heart Health Project prior to that, Canadian Diabetes Strategy, the Canadian Partnership Against Cancer. All of these types of organizations were looking for ways to prevent their diseases, not just to cure them or to treat them. It wasn't until 2006 that we had the Public Health Agency of Canada. So, seriously, we're almost 20 years in. But so this is the landscape that we're working with. Oh, whoop, this really is, it does trigger happy, isn't it? I did that one. Oh, then evolution in research funding and models. So we had the CIHR that started in 2000. There were many, as there still are, institutes focused on particular health issues, but also institutes with cross-cutting themes. Institute of Gender and Health. It's the first time gender was actually, like, people, and the people from the old Medical Research Council were going to these town halls at the universities going, what? We're not going to have money to do our basic research anymore. We're going to talk about gender, like what? And the Institute of Aboriginal People's Health, now the Institute of Indigenous People's Health, and the Institute of Population and Public Health. So all of a sudden there were these institutes that were a place where we could apply for research to address public health issues, even if those issues were associated with social determinants of health that people didn't immediately see as connected. So there were opportunities for developing new methodologies, which was great. And there were opportunities to build capacity through training and career awards. So CIHR started in 2000. I was privileged to be one of the first generation applied public health chairs. Started in 2008 to 2013. So, these were opportunities to really build capacity. How am I doing? So I'm going to go back to KSDPP for a minute. They just celebrated their 30th anniversary. 30 years. And they took this community from a place where diabetes was rampant and was considered a death sentence to a place where they really focused on prevention and changing the environment to make it, the healthy choice, the easy choice, for want of a better term. But their research went from their original intervention findings, when you look at the publications over the first 3 or 4 years from the NHRD, very little change in behavior, very little change in attitudes, very little change. But then with these opportunities through CIHR, for example, they started to be able to look at expanding the methodological repertoire. They started to be able to look at things like how the interventions and process changes in the schools and community. And that's important to know. How many of you in this room right now are thinking about how does community change? How do schools change? How does that support health? And these were things that weren't even considered important until, the 2000s. The value of social networking to promote health. The role of culture in school classes and community workshops. And they also host the Quebec, I guess, version of the Indigenous Youth Mentorship Program. So the goals in 2001 to 2006, they applied for a training program and were granted funding through CIHR to basically do training around community-based research in Indigenous health. So, and it's still going strong. I mean, like in the early days, it was sort of like, oh yeah, we don't have any more funding, but the people and the community were so committed that they just kept finding places to apply, and then eventually built this infrastructure that enabled them to be strong for 30 years. That's a success story. And a lot of that has to do with CIHR. Okay. Another case study that I'm going to talk about in a little bit more detail is something called Healthy Alberta Communities, which was part of my applied public health chair. And Kate and Genevieve both worked with me on that project. So they'll come on. Healthy Alberta Communities was a comprehensive 5-year community-based intervention project for obesity and chronic disease prevention. It was from 2005 to 2010. My applied public health chair started in 2008. So that's where I had the ability to add some innovative methods and do more of the community evaluation as opposed to what we were funded for, which was to evaluate whether or not people's blood lipids changed, right? So it was a university community government partnership. We were working in 4 unique communities. Our goals were to support environmental change within communities to promote and support healthy choices, to prevent obesity, improve health, and prevent chronic diseases, and to inform policy practice and research, research designs. So what we did, we had community coordinators that we hired that were embedded in each of these communities, knew the communities well. We targeted the environments. We weren't targeting people per se. We targeted the environments. So things like good food boxes to decrease food insecurity in basically inner city Edmonton. A Coalition for Active Transportation. This is 20 years ago in Medicine Hat. Coalition for Active Transportation, CAT, CAT. Medicine Hat is referred to as the hat, the cat in the hat. See, I don't do anything that isn't fun. I actually have a cat in the hat. I was given to me by Medicine Hat. But anyway, we leveraged resources that were already existing in the community. We didn't want to just come in, and we talked about helicopter research yesterday, but we didn't want to be a helicopter intervention, drop an intervention and then go away. We worked with communities to find out who was already doing stuff, and then we were able to use the expertise and the knowledge of the community coordinators and to to jumpstart projects with a little bit of an infusion of funds so that, things could get going. One of the things we worked on were capacity building and intervention development through workshops through the Angelo framework, which was called the Analysis Grid for Environments Linked to Obesity. So we went out into all the communities and had them identify what some of the issues were and who in their community could work on it and what resources were needed. That was a lot of fun. But remember, when this was originally funded, it was very much guided by very traditional research questions. Can community-based interventions reduce obesity and chronic disease risk? All the government wanted to know is, are the obesity rates going down? It's a 5-year project. 2 years was just getting ready. So what is the impact of interventions on obesity and chronic disease in healthy Alberta communities as compared to secular trends in Alberta? So we didn't have control communities. I think it was very wise Louise Potvin who we brought in and we asked, because she was doing, community-based intervention research. And she says, no, don't have intervention, don't have control communities. Use too much, you're going to use too many resources. Put your resources in the interventions and just compare to secular trends. Brilliant. So how have interventions and then we got a little untraditional with how have interventions contributed to changes in community capacity and environments. So the phone. Kate loved the phone. Kate was the research coordinator for this project. Yeah, we had the traditional impact evaluation. We had a phone survey when people actually answered the phone and had host phones. Like seriously, like for those of you who are really young, people used to have phones at home. And they were wired into the wall. And then we had measurement clinics to assess health outcomes. But with the Applied Public Health Chair, I proposed to expand our methodology and to expand our evaluation, to look at how do communities change? What is the process? And how does transforming environments influence health over the long term? So it was a real opportunity to grow. And anyway, the impact, was there an impact on the chronic disease risk factors? Nah, not so much. Self-reported well-being outcomes such as community belonging, food security did show some improvement. Okay. Measured health outcomes such as blood pressure showed some improvement, but we couldn't actually compare it to secular trends because we didn't have that data available. No impact on behavior change, no impact on body mass index or obesity. And I'm going to talk about something that Ev talked about this morning, the need for having longer projects, because translating changing environments into behavioral change and health impacts takes time. It's a slow process. Think of how many years that Apple Schools has been going on, and like, now we're, it's like huge impact, but it takes time. So when the grant funding was coming to an end, the Applied Public Health chairs back then were non-renewable. I started applying for grants to continue the project. And the reviews came back and they were brilliant. Everybody loved it. But one reviewer, and you've all been at the review table, or many of you have been at the review table, and when you think somebody puts a little question mark in there, and then all of a sudden the score goes from, what? Yeah, down. So the one reviewer said, I would be more supportive of this if this was novel. It totally discounted the 5 years of building that had gone into this. Totally discounted. And we could have done so much more and hit the ground running if, anyway, it wasn't to be. So it wasn't to be. But yeah, so like your point this morning, we need longer research projects to be able to see change. especially if you're working at the population level, sure, you can see a change in somebody's cholesterol in 6 weeks if you're working in a one-to-one, but in the population cholesterol, no, that's different. So we did do a lot of work around community evaluation. And what we found from the community evaluation is that the project did build local capacity to sustain community relevant interventions. It helped to advance understandings of how communities change and the work of doing that community work. And it demonstrated the value of partnerships that value that knowledge and expertise within the community. And then we started, we were growing the team, and Candace Nikiforuk, who was a second generation applied public health chair, had worked on Healthy Alberta Communities after Kate. And she started looking at, built environment, because she's a geographer. She looked at the built environment and how that influenced. So it really gave us an opportunity to start looking at other things that were influencing health. This is a model that was developed in Genevieve's master's research. And this is still online, and there's actually an online resource where you can click these boxes. These are the stages that the communities went through to develop interventions: networking, partnering, prioritizing, planning and implementing, and supporting and sustaining. And you can go on there and click, and you can still hear the community coordinators talking about how they did this, which is really cool. And so important stuff. So what happened next? Well, the last stage in Genevieve's model was sustaining. Many of the projects actually did become sustained, even when the grant funds were gone. So for example, the cat in the hat became housed at the Be Fit for Life Center. So things like this, like projects did, because we worked with existing resources in the community. We share our experience with others. We are a resource for communities. As I mentioned, that's the website if you're interested in going on and seeing how the Building Healthy Communities works. We worked with Alberta Health Services to talk about adapting the model to expand through communities in Alberta. I forgot about this until yesterday when we were listening to the ARC at Alexander. I worked with Noreen Willows, the person who's forever on the advisory board, who's been on ARC since the beginning and is still on ARC even though she's retiring. We went in, and Kate, you were there too. We went in and we did those Angelo workshops with a group of community members to come up with ideas about what could be done around childhood obesity in Alexander. We didn't have, and this was clearly stated from the outset, we didn't have funding to fund interventions, but the community did come to some priorities, including healthy schools. So that's kind of cool. And then, as I mentioned, it became a platform for connected projects, such as the role of place. CHBE, CHBE, stands for the Community Health and Built Environment. And then we became, we sort of informed policy advocacy. And I know a lot of you have been talking over the last couple of days about how we really need to be doing, as applied public health chairs, advocacy to advance health. And so we developed a coalition called the Alberta Policy Coalition for Chronic Disease Prevention. That's the Angelo workshop in Alexander. So because of the applied public health chair, we were able to develop novel research designs and methodologies. We really were able to help understand how communities change and how transforming environments influences health. We were able to use unconventional designs and methods. Even though we were met by some resistance, we still had to measure. We had to measure weight. We had to measure blood pressure. We had to measure, cholesterol, stuff like that, because, there was that accountability to health outcomes. So I really do think that one of the legacies of the Applied Public Health Chair program, from my perspective, was enhancing acceptability of an expanded repertoire of research methodologies and research designs. Okay, so I'm going to sum up community engaged research and health. How did we evolve in my career and in some of your before your lifetime to now? We started out talking about things like participatory action research, community-based participatory research. Again, we heard this morning that those terms were used in organizational psychology back in the 40s, but not adopted by health until much later. One of the things that we were talking about just even in our introductions yesterday was we now have expanded definitions of what we mean by community. I mean, when we think about community, a lot of times we think about geographical community, or a particular First Nations community. But could it be people with lived experience? A community of people, for example, living with obesity? Could it be a community of practitioners who are trying to think about ways of doing things differently? Could it be a community of researchers like those of you in this room who are trying to think about ways to move forward? Okay, those are all communities. But one of the insights I got yesterday was the idea of belongingness. If we think about where do we belong, that actually applies to all of those community definitions. So the other thing is what we mean by engaged has also changed over time. Is the community, can they only be engaged if they're the ones who ask the questions? Or can they be engaged if they see that a question that arises from some other way is relevant to them? And I was thinking about the example that was discussed yesterday about pharmacy in Alexander. Knowledge users, implementers, are that they need to be engaged. So, is it community driven? Is it community owned? Is community change the target? These are all things that we still grapple with and we need to have discussions about. Obviously, we have to think about when we work with First Nations communities of OCAP, ownership, control, access, and possession. I've seen the term citizen science be used to talk about engaged research. I've seen, well, when we think about what was asked of us when we had to talk about in our grants how we were doing integrated knowledge translation, that usually meant engagement. On the CIHR website, there's a big thing about gender-based analysis plus and how we have to be thinking about the intersectionality of all of the how different culture, gender, economic issues are impacting this research, and even implementation science. Like all of these are terms where we can learn things from that have to do with community engagement. Okay, moving forward. And as I said to you, I'll be quick on this part because this is your work, not mine. I'm retired. This is the only academic thing I've done in 2.5 years. And it's been really fun. It's not the most fun thing I've done in the last 2.5 years, but it's the most fun academic thing I've done in the last 2.5 years. And I really miss my sleep. Retirement, the best thing about retirement is catching up on 40 years of sleep deprivation. But anyway, moving forward. This is a picture that I have used in every single academic presentation I have given since I moved to the University of Alberta in 1997. These are my children in 1997, aged 7 and 3. And they're in a big moving box because I was moving from Halifax to Alberta. And they're so damn cute. right? But it gives me an opportunity to say, let's think out of the box. Okay. So they're in a box, they're in a moving box. I had to add this picture in because it's opening night for the Edmonton Oilers tonight. And the last game that they played in Edmonton was the second last game of the Stanley Cup final last June. This is me and those two kids in the box. I'm the one in the middle. So anyway, so instead of just thinking about out of the box, let's think big because they're big. And let's go. Not just Oilers, let's go us. Okay. So these are some of the things that I have sort of captured over the last few days. Working across disciplines and cultures. These are your ideas. These are the words that came out. Relationships, respect, reflexivity, humility, listening, openness to diverse perspectives, courage to fail, curiosity, to support each other and cheer. I'm going to do it, Kim. I'm going to do it. I'm going to do it. I have to do it again. As soon as you said cheer, I had to put that in there. Sorry. Okay. Think about the resources. We had a wonderful presentation by Pam this morning talking about the fact science strategy, and it's a wonderful document and it's a wonderful foundation for us to think about. My favorite part was the science culture, which includes things like inclusivity and can't read it. Agility for relevant science. You know, these are important. Scientific integrity, trust, inclusive community, open collaborative science leadership, science excellence for innovation. So there's lots more to that document, but it's something that I think, not me, I'm retired, but you can be thinking about as you plan your future research. I mentioned gender-based analysis plus at CIHR, and there was a section on the research, and I wondered when Kate was talking about this morning, if this was a tick box thing or if this is a genuine, I don't know. I'm not going to pretend I know. But there are some other interesting resources out there that have actually been published since I retired. And thanks to Genevieve for forwarding some of them to me. The Community Engagement for Impact Framework, an evidence-based strategy to facilitate social change. I chose to read this one because it had the word social change in it, and that's my passion. And it talks about what you can do at the discipline level, which I'm not going to go into, but at the research level and at the university level. So as a research level, all of you, think about individual researchers can best prepare for community engaged research by fostering a genuine interest in community engaged research, by improving your skills in community engaged research, by establishing connections with government and business or other community organizations, by developing a strong record of achievement in community engagement, and in balancing the interest in community engagement and academic pursuits. The university, and many of you are leaders in your universities. So when we think about what can universities do to support community engaged research, well, there needs to be recognition for this work. There needs to be recognition at faculty evaluation committee that maybe there's no publications or few publications for a few years because it's all that development work happening. But then it comes later. I can't tell you how many times I've written letters of support for people who are applying for tenure and promotion, who had done this kind of work, and how much I spent laboring over what I said because I really wanted the message to get across that this is important work. It has to be valued, and it's different. And I know that there are frameworks like DORA, that talk about different valuing research and such, but I just want you to think about that. How do you have a role in that? And Kari talked about this resource yesterday, Facilitation for Community Transformation. And I read about it and it said community engaged research is constituted by the active participation of the people in the communities who are most affected by research. Yeah, that's what we are doing. And as such, we need to facilitate those connections. So this is a great resource. Thank you. So I'm going to finish here. I actually went a little over because I told too many stories and I did 2 star jumps. But community engagement in health, engaging communities in research to create an evidence base for influencing policy and practice requires a marriage of multiple methods and a lifetime of commitment to continued learning for all of us. It changes us as researchers. And you, me as an alumni, but you as a applied health, what are you? Applied public health chairs are a community. And I guess I put out that question. Are we actively engaged in changing research culture to promote health in this way? I think you are, but I think maybe we need to tell the story in a very strong way. That's it. Sorry for going a little over. Do we have a couple minutes for questions? Okay, we have a couple minutes for questions. I did start late because Kate talked way too long introducing me. And I know people are going to I'm not offended. I know you're not leaving because you're offended by what I said, I hope. Thank you. Oh, are there any questions online? Yes. No. Okay. Yes. Yes, you can ask a question. Thank you. Bye. Yeah.
I'll start. And I can move it around. So I know, oh, whoa, that was really loud.
Yeah.
Maybe my question is, and it's interesting because I remember all of those grants we were writing. It's not novel. Oh, there's just waving. Oh, are they waving or is there questions? Oh, okay. I was like trying, someone getting my attention. Like that was 20 years ago. It's not novel. Need to do something new, have the same outcomes. 10 years ago, but it's still happening. And so it's interesting. Like Tina and I were reflecting on that and writing funding applications for the Indigenous Youth Mentorship Program, facing the same things. Like you're not in the implementation stage. Well, what are we then? You're not in like the new stage. So it's crazy because I remember you saying this when I was your postdoc that, you know, people would say like 10 years ago, we were hearing this, we're still hearing this. If that's an actionable change, like what do we do?
I don't know. You answer the question. I mean, like I think it is part of the whole research culture that research is about novelty, new ideas, new, and and it is. But novelty is more than just starting in a new community or starting over. Novelty is creating new, like look at KSDPP, creating new ways to advance our knowledge that's relevant to those communities. And over 30 years, they were able to do it. I think they were super successful and they probably got some of those comments too. But because they had such a strong, it was community driven. And the community members are such leaders in this area. So I don't know. It's your thing to answer. I'm retired.
And I should add, like Kim was running the Berlin Marathon when I asked her to, she was getting ready to do that. So she came out of retirement and out of running.
I was wondering if you could speak on what your favorite project was and what project you were most proud of, and if they were the same.
good one.
I have to say Healthy Alberta Communities was my favorite project because the people that we worked with, people in this room, were so awesome. And because it really did start to, we saw sustainability. No one would look at some of the projects that are happening in small communities in Alberta now and say that was because of Healthy Alberta Communities, but it was. So I think that would have to be one of my favorites. And because, we did have more than 5 years to really delve into the ideas. But, they're all my favorites in some ways. So even with all the mistakes that I made with the Mi'kmaq communities, um, this was 1994. My youngest son was born in 1994. He came with me to the communities. Maternity leave back then was 4 months. Like, he came with me to those communities. And there is a child who's now 30 years old who came from Membertou, whose name is Dustin, because the people that I was working with loved the name of my child, Dustin. So that was kind of cool. I think my favorite projects are those that I feel a strong connection to. And how do you measure that? Hmm.
Oh, okay. Well, I can walk.
So one, I'm curious how you survived 40 years of sleep deprivation. Um, and then I guess the next thing is like, it's clear that you were highly motivated to do the work and that there was a lot of hours and a lot of labor. And I'm just curious, what was the foundation that allowed you to take on such a huge endeavor?
No one has ever asked me that before. That's a really good question. How to survive 40 years of sleep deprivation? You'd retire early and catch up. But that's that. But I don't know. I just from the beginning, as a practicing professional, I had questions, and I just didn't see the way that we were doing things as the right way, and I wanted to work in a good way, and I didn't know how. But I tried to learn from as many places that I could. I tried to do things like being open to new ideas. If I had gone off to graduate school and done a PhD in nutritional science, I wouldn't be here. It was because of necessity that I went and studied in this interdisciplinary context. And I'm so glad, because it really increased my passion and energy. When you have passion for something, you have energy to do it, even if you're falling asleep in meetings. That's the part that Kate didn't tell you. Like, you did say that I fell asleep in the meeting. Yeah, I said, I forget that. I don't remember. She was, of course you don't remember that. You were asleep. But so when you have, and you all know that, you're researchers, you're career researchers, you're passionate about what you do. Passion is what gets you through the night when you wake up trying to figure out how to do something. Passion is what gets you through everything. So just keep being passionate. And I retired early for 2 reasons. One is people like Kate and Genevieve and Candace, they had way more knowledge and energy, and they had far surpassed anything that I had done. I was leaving this in good hands. I had no concerns that community-based participatory research was just going to fall off the side of the planet. The other thing, I was sleep deprived. But the other thing is, even though I had passion still for the research, there were other parts of my job I no longer had passion for. And I say to people, I absolutely loved my career. I loved my job until I didn't. And then I knew it was time to go. So, does that answer your question? It's just, I'm just musing. Okay. Seriously, when Kate asked me to do this, I said, I have nothing I can contribute. Really. You guys have far surpassed, but she convinced me anyway. And I have had a few sleepless nights. I really can't wait to get back to Victorians. Okay. Okay. Thank you.